Welcome back to my channel, Pattern of Good Works. My name is Donna, and today we will resume chapter 11. Remember that the book is called The Specialty Practice of Rehabilitation Nursing, a Core Curriculum, the 8th edition. So on the top of page 196, we want to go back to assessment. That's what we talked about the last time. So in assessment, there's something called the bulbar wink or anal reflex. And what we're trying to do when we have the patient turn on their side, visualize the anus, we're trying to assess the rectal tone. So what will need to happen is to test this, we use a cotton applicator and it's gently stroked in an upward motion over the rectal sphincter. And immediately or spontaneous contraction should occur, and that will let you know that the patient's spinal cord is intact. If they have a spinal cord injury, you may see something else. So in the case that they have what is known as a lower motor neuron event or injury, and that's usually below the level of L1, you may see no anal reflex. They may have a flaccid bowel, low to no motor tone of the anal sphincter, and they may have some fecal incontinence. And this is also typically diagnosed as a reflexive neurogenic bowel. When the patient has sustained a level of injury above T12, they have what is known as an upper motor neuron injury. And you may see an anal reflex, but they will have difficulty passing stool. They may have some hypertonicity, which may indicate or have some spasticity of the rectum. So they will have some fecal residue or leakage. And they may be diagnosed as a reflexive neurogenic bowel. So on page 201, at the top of the page, the header says stabilize dietary routines. So the nurse or the CRRN nurse wants to encourage the patient to maintain daily meal scheduled. This is not the patient that you want to have them just not eating throughout the day on a regular basis. And they should eat at consistent times with adequate balance of proteins, fiber-rich carbohydrates, and fats. They also mention, just like when we met the last time, avoiding constipating foods. Now, under step 4, it goes into talking specifically of managing upper motor neurogenic bowels and lower motor neurogenic bowels. So for the lower motor neurogenic bowel patient, it says they are at high risk for fecal incontinence if bowel care is not routinized. So they must be on a routine to ensure that they avoid constipation as well as fecal incontinence. So some patients may need to have a bowel program twice daily, in the morning time and at the night and in the nighttime. These type of patients also should have stool that's firmer. Remember, they're leaking. So stool should be firmer to prevent bowel accidents. We want to promote optimal fiber intake of at least 20 to 25 grams daily. Supplement with a bulk laxative. Rectal medications is necessary in most cases. So these individuals may have a suppository or they may have a mini enema. With digital stimulation and manual evacuation of stool from the rectum every morning and PM. So depending on what the physiatrist will order, you may need to perform that bowel program and make sure that the rectal vault is empty. And nurses should know that you need at least 30 minutes of RN time to be scheduled for care. So this is the type of patient that you want to let all the other patients know, hey, I'm going to be in this room or I'm going to be performing a bowel program, to give them ample comfort, as well letting them know that this ahead of time. And if they need anything from you, to try to get that done before you go in to perform your bowel care, because you're going to be in that room or with that patient for some time. For an upper motor neurogenic bowel management. It says if the patient cannot safely sit upright, maybe they don't have torso support, you want to perform, or trunk control, you want to perform bowel care on the left side while in the bed. Schedule bowel program every day or every other day based on stool quality. And you remember that we have the Bristol to really assess the quality of the stool. Administer oral stimulant laxative 8 to 12 hours before planned bowel movement or bowel care. And those kind of medications, a stimulant would be like a Senatap. Provide evening bowel care, again, 30 minutes after the last large meal, and administer rectal stimulant laxative, having the patient upright on a BSC, and then provide digital stimulation as needed and monitor for autonomic symptoms. So remember, T12, always on the lookout for an autonomic response. On page 204, there's an algorithm that looks at diarrhea and fecal incontinence. And remember that any active diarrhea may be due to a myriad of things. It could be watery due to medication or side effects. It could be related to an overdose of laxatives or recent abdominal surgery. Again, if there is a bloody stool, that was watery. If there's a bloody stool, it may be indicative of an ulcerative colitis, C. diff, Campylobacter, Shigella toxin producing. It may be E. coli, or it may be a symptom of malignancy. If there is mucus, fatty, or foamy stool, it may be due to hepatobiliary disorders, malabsorption syndrome, like we talked about steatorrhea the last time we met. It could be related to lactose intolerance, gluten or wheat intolerance. Medication side effects can also cause this. And lastly, all of these diarrhea matters, whether it be watery or bloody or mucus, will warrant further testing. So you can have a stool culture occur. And then identify whether it's related to medication, such as magnesium containing antacids, or is it related to calcitonin or colchicine, or identifying the underlying cause or infection is going to really help to dictate the manage of the diarrhea. So I briefly want to talk about on page 205, fecal urgency with or without fecal incontinence. So it says that the clinical features may look like this. One is the patient may have a rectal sensation. It may be present. They may have some soiling or leakage or seepage. And there is a failure to control defecation. So the nursing interventions that are accompanying this are resolve any underlying constipation and rule out impaction, first and foremost. We want to promote an adequate fiber intake from natural diets, and you really want to, again, aim for 20 to 25 grams of fiber. And this can include bran, ground flaxseed, prunes, or prune juice. Begin pelvic, floor, and anal sphincter exercises with PT. Consider 3-day nightly glycerin suppositories after dinner to promote regulating bowel control. And then check for or treat if there's any dermatitis or ulceration of the perianal skin. And always we're going to measure and evaluate outcomes again. And if needed, you will have daily or every other day bowel movements. Then we can then say, okay, the patient is meeting their goals. We want to have manageable stool consistency. We're going to use the Bristol stool chart to assess that. Contained or reduced bowel accidents. If they're having bowel accidents, it should be, or hopefully prevent bowel accidents so there's no leakage outside of the adult brief or onto their clothing. Education of the patient at every bowel care or the caregiver. And there should be an interaction or emphasis for self-home planning. Of course, we always discharge planning at day one. And then as much as possible. And then home care, home caregiver support is arranged before discharge. So again, you want to get ahead of the fecal urgency with or without fecal incontinence so that the patient can have a safe care transition on their way home, and the family and or caregiver will feel supported in this journey. So this week we have the opportunity to share on upper motor neuron disorders, lower motor neuron disorders. We talked a little bit about fecal urgency and diarrhea. I thank you for coming along on this journey. We want to ask that you would like, comment, and subscribe. We're wishing you all the best. Continue on the CRRN journey to success. Take care. Bye-bye.